Welcome to this Clinical Explainer. I am absolutely thrilled you're tuning in today. For this session, I'm firmly putting on my senior therapist hat to be your mentor through a really foundational masterclass, the psychodynamic assessment of the patient. Our goal here is completely transformative. We're going to move you away from being those rigid, robotic medical history takers and mold you into deeply reflective, dynamic clinicians. We'll explore exactly how to look way beyond the surface of a simple chief complaint so you can start to understand the deeply human, unconscious forces that are at play in your very own consulting room. All right, let's dive right in. I want you to think about this profound quote by William James for a second. Whenever two people meet, there are really 6 people present. There is each man as he sees himself, each man as the other person sees him, and each man as he really is. What's so brilliant about this thought is how perfectly it captures the unseen, incredibly complex layers of expectations that literally fill the room the exact second a patient walks through your door. When you sit down with a patient, sure, you're two strangers making contact, but neither of you is a blank slate, right? You both carry these internal representations of yourselves, projections of the other person, and of course, the grounded reality of who you truly are. So your first job, it isn't to just fix them. It's to establish rapport and acknowledge all these invisible guests. Here is the roadmap for our time together today. We'll follow a chronological journey, starting with the initial handshake in the dynamic clinical mindset. Then we'll move through transference and countertransference, the art of listening, and weaving the mental status exam. Finally, we'll pull all those pieces together in the psychodynamic diagnosis to construct our final biopsychosocial formulation. Okay, Section 1, the dynamic clinical mindset. Time to rethink the medical model. We really need to completely overhaul how we view the traditional medical model. I want to shift your perspective right out of the gate by dismantling that intense urge to just isolate and treat a chief complaint as fast as humanly possible. Look, in psychiatry, if you try to steer a totally linear course, you are just going to hit potholes. In linear medical interviewing, like a doctor evaluating appendicitis, the mindset is super clear. Diagnose first, treat second. Keep the pace fast and pursue those symptoms directly. But in collaborative dynamic interviewing, that distinction between diagnosis and treatment is entirely artificial. The diagnosis literally is the treatment. As dynamic psychiatrists, we know that the very way you take the history is inherently therapeutic. You absolutely must slow down. Engage the patient as a collaborator in this exploration rather than treating them like some passive specimen of pathology. So how exactly do we build that collaborative rapport? Well, first off, avoid using hollow reassurances. You know the ones, don't worry, everything's going to be all right. Patients have heard that a million times from their friends and family, saying it just signals to them that you don't actually grasp the depth of their suffering. Instead, embrace genuine empathic immersion. Say something like, I can completely understand how you feel, considering what you've been through. It's a simple shift, but it profoundly validates their unique experience and builds a very real therapeutic bond. Moving on to Section 2, transference and countertransference. Welcome to the invisible room. Let's talk about how past relationships actively repeat themselves in the present moment, right there in the chair across from you. The big concept here is countertransference. In a regular medical setting, if a surgeon suddenly feels angry, bored, or intensely sad while examining a patient, they just view that as an annoyance and push it down. Well, we are flipping that script entirely. For us, those internal feelings are pure gold. They're crucial diagnostic information. They literally tell you what kind of reactions this patient naturally elicits in other people. If you're sitting there feeling inexplicably bored or totally enraged, pay attention. That is vital clinical data. But here's the really tricky part, the million-dollar question. How much of that countertransference is actually your own stuff? As a clinician, you have to relentlessly self-monitor. Like maybe your sudden frustration is actually about your own unresolved conflicts with authority, or maybe it's some unconscious need you have to be the ultimate savior for this patient. You've got to sort out what personal baggage you're dragging into the room versus what the patient is actively inducing in you. Because to truly use yourself as a clinical instrument, you have to be totally attuned to those inductions. Let me share a really fascinating anecdote from the text. A child psychiatrist noticed she would occasionally develop this completely irrational feeling of anger, even an impulse to abuse her patient. Now, rather than acting on it or just suppressing it out of guilt, she recognized it as a sign. She realized, wow, I am sitting with a victim of child abuse. The patient's internal abusing object had actually been projected right onto her. By absorbing that projection, she gained a truly profound understanding of that child's internal world. It's a real game changer when you think about it. Section 3, the art of listening. We're looking at associative anamnesia. So, Recognizing all those invisible forces requires a very specific mechanical approach to the interview. I want to teach you the rhythm of uncovering the unconscious mind. Mastering this takes a highly flexible style. Step 1, just allow unstructured rambling. Seriously, it is not wasted time. Neuroscience actually shows us that this free-ranging mental activity lights up the association cortex and kicks off free association, revealing hidden connections in the mind. Once the patient has freely rambled for a bit, then you smoothly transition to step 2, a structured pursuit of the hard facts. You fill in the gaps, build the timeline, and hit your descriptive diagnostic criteria. It's really a dance between wide-open exploration and targeted investigation. Let me give you a brilliant example of why that unstructured rambling is absolutely crucial. Take the case of a 31-year-old guy who came in complaining about how he just couldn't hold down a job. Right after he made that complaint, out of nowhere, he became completely overwhelmed with panic about where his parents were. They were waiting in another building. Because the psychiatrist was listening for associative amnesias, which just means paying attention to the exact order topics are brought up, he caught the connection. That seemingly random sequence exposed a deep, unconscious fear. The young man secretly believed that growing up, holding a job, and becoming independent would somehow destroy his parents. There's no way you catch that kind of insight if you don't let the patient's thoughts flow naturally. Section 4. Weaving the mental status, going beyond the words. Look, as dynamic clinicians, you have to learn how to naturally weave the mental status exam into the actual conversation. Please do not just tack it on at the very end like you're reading a robotic checklist. When you integrate it smoothly, you catch all these little nuances in cognition and language, things like parapraxis, slips of the tongue. Think about this pregnant woman who was referred for a consultation. She blurted out, "I don't want to be a psychiatric patient." That slip? Definitely not an accident. It totally betrayed her deep, unconscious ambivalence about becoming a mother. If you're just staring down at a clipboard checking boxes, you are going to miss the absolute goldmine of data hiding right there in those tiny linguistic glitches. And of course, you've got to look way beyond the actual words to assess affect and action. I absolutely love this visceral quote from Sigmund Freud. "If his lips are silent, he chatters with his fingertips. Betrayal oozes out of him at every pore." It's a great reminder that no secret can ever truly be kept if you just know how to look for it. Ask yourself, what specific subjects make the patient fidget? When exactly does their posture shift? Paul Ekman's research on microexpressions backs this up entirely. Our faces and bodies are constantly betraying our hidden emotional themes. Nonverbal action is basically a royal road straight to the unconscious. All right, Section 5, the psychodynamic diagnosis. Time to get the complete picture. Once you've gathered all these amazing clues, the history, the transference, the nonverbal oozing we just talked about, it's time to assemble the specific diagnostic lenses. We want to understand the patient as a whole human being, not just a DSM label. You can't rely on just one single theory here. It's like a giant puzzle. You look through the lens of ego psychology to check the reality testing, impulse control, and what defenses they're using. Then you use object relations to look at their interpersonal patterns. Do they see people as whole individuals or just parts that exist to gratify their needs? You evaluate the self to see how cohesive they are and where their self-esteem sits. And finally, you pull in attachment theory to gauge their internal working models and their capacity to mentalize. Pluralism is the name of the game. By holding all these different frameworks in your mind at the same time, you avoid being reductionist, and you end up constructing a really rich, complex, and totally customized treatment plan. Which brings us to Section 6, the final biopsychosocial formulation, the blueprint. This formulation is the grand finale of your assessment. It's the literal blueprint where we synthesize all that descriptive and dynamic data into one concise working hypothesis. Building a solid, actionable psychodynamic formulation requires 3 key points. Point 1. Write a quick sentence or two describing the clinical picture and the exact stressors that kicked off the crisis. Point 2. Build your explanatory hypotheses, biological, intrapsychic, and sociocultural. Basically, answer why is this happening right now? And finally, point 3, state exactly how those first 2 points directly inform your treatment plan and prognosis. Let's actually apply this framework to a real example. The case of Miss A. She's 33 years old and presented with paranoid psychosis, entirely convinced her mother was plotting to kill her. Okay, what was the stressor? Her brother had just moved into her apartment and was living totally parasitically off of her. Dynamically, we know that Miss A usually relies on a massive denial of her own anger just to function day to day. Her brother's exploitation completely shattered that denial. Triggered by this intense, overwhelming rage, she suffered a psychotic regression. She essentially split off her own murderous feelings and projected them onto her mother. Because she didn't really have the psychological mindedness for deep insight therapy right then, our dynamic understanding led to a very practical treatment: medications to stabilize the psychosis, and immediate casework to physically get the brother out of the apartment, which restored her defensive equilibrium.
And that brings us to the end, but I want to leave you with one final burning question to think about. In your very next clinical encounter, are you just going to mechanically take a medical history, or are you going to abandon those internalized biases, drop the rigid checklists, slow your pace way down, and truly listen to the 6 people in the room? All those unseen forces are just waiting to be explored in your next session. Thank you so much for joining me for this clinical explainer. Now get out there and really listen to your patients.